version for the patient, because even if we put the final shell inside, you can still dial this to the best version for this particular patient to get the best rotations on the table. And if you look at here, if you remove a bit of plastic here and there, you get better range of rotation before you get the impingement. Okay. Radiographically, we see no lucencies around the implants. There was no notching, no linear notching in 77 out of the group. We had mild notching in 21 that appeared late, about 3 to 4 years after surgery. Stress shielding in stem prosthesis is something that started to be reported recently by a group of Gilles Var's group, and then by Luc Favard as well, with very high rate of stress shielding. What do you do with this if you have to revise it? It's a major problem. It's a major problem. So we haven't seen any stress shielding, no humeral subsidence, no lysis of the tuberosities like they've seen there, because there's a direct contact pressure here. We don't have any shield of the pressure. Another, I think, thing to think of is these elderly patients, and this lady is with this fracture here. They tend to fall, and if they fall, they fracture, and they fracture usually periprosthetically. If they have a stem prosthesis, they usually fracture in the mid shaft below the prosthesis. Because this is a metaphyseal prosthesis, if they fracture here, usually you can treat them conservatively, and they have a reasonable range of, not as good as she was before, but she's happy with that. She can live with that. I had to revise only one case to a stemmed verso because of that.
Cemented or uncemented?
Uncemented.
Even in revisions?
Yeah, uncemented. But if you want, you can put cement. Now, that's what I said earlier. We don't know what waits for us here, or wait there, or wait there in the life of the patient. So this is a journey, and we have to really think about what our next step is. Yeah, what we'll do next. And this is just to conclude. This is a young lady, rheumatoid lady, at the age of 22. She had a couplet surface replacement. This has lasted 23 years, but at this stage the cuff has failed, and I revised her 2 years ago to, actually more than 2 years, 3 years ago, to the verso. And this is her range of movement 2 years after the verso. Okay? I don't know if this will last the next 50 years of her life. I don't know. But I know that I've got all the bone stock here, and if I have to do something else, I can do it later. You know? This guy is cuff arthropathy, and he came 10 weeks after surgery to the clinic like that.
Yes, fantastic, look. It's brilliant. Come on. How about that? Round the back, over the top, round the front. Yeah.
Okay, so I'll just carry on, move on from that. It's enough. This guy we've seen before with the fractures. Again, we have there is a stemmed version for revision of stem prosthesis or non-unions. And just to conclude, this is a different design without a stem. Shows encouraging, excellent mid-term results. Low incidence of glenoid notching and low stress shielding. Improved rotational movement. Again, this is really important. And it seems that the primary reverse shoulder does not need a stem. And preserving all the bone is preserving all the possibilities, and it may be used in younger patients as well. Thank you very much.
Any questions? No microphone. Here? When I was in Sweden 3 years ago, I stayed about a month seeing some reverses with Dr. Anders Eklund. And he used it to say that you can only have external rotation with a lat dorsal transfer. And I saw many. and actually you are having good results without it. But actually, what do you think about the addition of electric doors transfer to gain external rotation? Because in San Diego, people say that this is a must.
Well, you see, I mean, we don't have enough time to go through all the, but in the vast majority, 99% of the cases, in this case, you don't need to have that. And if you ask Mark Frankel, he will tell you as well it doesn't need to do latissimus dorsi transfer. And that's because we have a little bit of lateralization of the center of rotation, okay? Doing the lateralization with the fact that we have this, remove a bit of plastic from both sides, makes that the anteriormost fibers of the deltoid and posteriormost fiber of the deltoids are more horizontal. And they are actually working as rotators as well. So it's not a strong rotation, but it's enough for their daily function, okay? If you have someone who's got, really severe and you think that you want to assure that he's got good external rotation, the laparoscopic operation is a great operation. Add it, yeah. You can add it in any operation. With this, with a stem.
I have been doing few reverses, but in any reverse I do in Brazil, I add electric doors transfer.
I didn't do it yet.
Okay.
I didn't do it, and I've got good results.
Useless?
No, I think there is a place for that, but
Okay.
it's like a lot of operations. Sometimes someone says something, suprascapular nerve release.
Yeah, I understand.
Yes, I've done it 2 or 3 times, but I'm not doing it every time. I will do it, yes, in 1 or 2 cases that are necessary. Yeah.
I think we move on to the next session. Thank you very much, Dr. Lev.
Thank you. Pleasure.
Thank you.
Thank you very much, Wafa, for this brilliant talk. We'll come to almost the last phase of this meet. It's a panel discussion on partly stiff shoulders, but majorly on arthroplasties. I'd invite Dr. Basim, Dr. Maheshwari once again, Wafa Levy, and Ashish, please. Okay. So we'll leave Ashish here. Sergio, how about you, please?
Okay. Who is asking the question to whom? We are asking questions to you.
Your child is asking you
No, on the other side of the firing line.
Now we have to see whether your child has gone wayward.
You know my viewpoint. That's my problem. No. This is okay.
See, that's the problem with children. You can't, you can teach them, but then
They ask you the wrong question.
in the wrong time.
But in Delhi, you need to have parental guidance.
Yeah.
I think most of the questions have in, so there's a panel discussion on frozen shoulder as well as, it seems, इसका कुछ resolution change करना होगा, excuse me.
क्यों?
ये कुछ ऐसा लग रहा है ये.
फर्क पड़ रहा है, ये करते हैं, ठीक है.
Okay, it looks a little weird to me, isn't it?
रोज का डोज नहीं मिला.
Okay, we've already talked about the frozen shoulder. Most of the questions are answered. Any questions in the frozen shoulder? People have any questions in the frozen shoulder? Okay, so we have the panelists. We'll start with the audience. What is the understanding in the audience? What do you think is the frozen shoulder? We all know that frozen shoulder is restriction of motion. Can I have the mic? I will. We know it's a restriction of motion. Is there anything more to it? Is every restriction of motion a frozen shoulder? Huh? Painful restriction of, okay. It's a painful restriction. Most of the restriction of motion is painful. Anyone? So for it, that means all the restriction of motion or stiff shoulder, all shoulders which are not moving are frozen shoulder. Is that true?
No.
No?
Osteoarthritis
Why do, yeah.
Osteoarthritis can be painful.
So yes, even osteoarthritis with no joint space.
Or a chronic fracture dislocation.
A fracture dislocation will have no external rotation, posterior particularly. So what is the definition of frozen shoulder? We should, before we start discussing the frozen shoulder, let's clarify what is the definition of frozen shoulder from our experts.
So frozen shoulder for me is like headache. What is the definition of headache? That you get some pain in your head. So it is like any shoulder which is not moving for whatever reason, it's frozen shoulder. Now if you say what are the causes, I would say adhesive capsulitis is one of the cause of frozen shoulder. Another cause is osteoarthritis. Another cause is post-traumatic. So I don't equate frozen shoulder with adhesive capsulitis. Because as soon as I say
let him
finish. I don't equate because as soon as you say frozen shoulder and it is frozen because of any reason, you don't. As soon as you say adhesive capsulitis or typical frozen shoulder which has a curve that recovers spontaneously, it gives you that little bit of lax attitude that it will recover itself.
So give me define frozen shoulder in your words.
A painful limitation of shoulder without any significant trauma.
Okay, so that is
in a 30 to 50 year old.
Okay.
It's a global loss of range of movement in otherwise normal shoulders. So no athletic shoulder, nothing that really restricted.
No other pathology.
No other pathology that you can find, but it's a global loss. So it's loss in all directions.
Yeah, I will say the same thing, but in a more, let's say, beautiful way. Is the definition that is written in my preferred book, that is complex and revision problems in shoulder in shoulder surgery. Frozen shoulder is a condition of unknown etiology that is characterized by simultaneous passive and active limitation of range of motion in the absence of an articular disorder of the shoulder. And I fully agree. So I'm saying again, frozen shoulder is a condition of unknown etiology that is characterized by simultaneous passive and active limitation of range of motion in the absence of a known articular disorder. What would be a known articular disorder? Arthritis, as he said, a chronic locket dislocation, and so on.
Tumor can also cause.
Well, I just want to add that, as just in a bit of a joke way, that Tim Bunker worked a lot on frozen shoulder, and he coined the term HGAC, which actually initially stands for humeroglenoid acromioclavicular syndrome, or haven't got a clue.
So what actually Dr. Maheshwari was trying to say was there are different types of adhesive capsulitis for the shoulder.
Can I just clarify what I said?
You will confuse us again.
No, there are three terms. I don't want to confuse myself. Maybe I've understood it wrong. There are three terms I don't want to mix up. One is stiff shoulder, one is frozen shoulder, one is adhesive capsulitis. I cannot loosely use them one for another one, because as soon as I say adhesive capsulitis, refer to physiotherapy. As soon as I say frozen shoulder, I want to examine that very thoroughly for any possible osteoarthritis, any maybe subacromial.
That's where the difference, because you're talking about stiff shoulder.
Yes.
And stiff shoulder you want to investigate.
Yes.
Now stiff shoulder can be frozen shoulder.
Yes.
But frozen shoulder is a definitive, distinctive diagnosis, which is what's written here.
Yes, it's idiopathic. There is no cause. There is no identifiable cause with any radiological investigation. Be it mostly X-rays, but even MRI. There should be global.
We could just add what I just said: the absence of articular known disorders.
Yes,
Well,
but
absence
that's a neurological
significant-
finding.
Okay.
Yeah.
that's
So,
better because tumor can be extraarticular.
Yeah.
Yes,
and
yeah.
it still cause a frozen shoulder.
Yeah. So absence of significant radiological findings. Yes, you want to add something?
Percentage of restriction.
No, I don't think that you can percentage.
No.
You can quantify it. No. Some people say more than 50% and all that, but I don't think I think you're making it more technical unnecessarily.
It's really more
Yeah.
difficult because
Yeah.
some people are very lax and they can
Yeah.
compensate more with the thoracic
Yes.
movement, and they will have more externalization, but they're still stiff. Because normally they get to 90, now they get to 20.
No, but they can have a little bit of axial motion.
Yeah.
But the rotation is disproportionately affected in frozen shoulder.
Sure. The rotation is the only movement that you can't compensate with a thoracouscular movement.
And that is where your no ER. Would you like to talk about your no ER?
There's nothing called periarthritis shoulder. Now where do you put all these terms?
No, periarthritis
It's an old term.
So
I'm sorry.
nobody uses
It's
it.
in the
Nobody
West.
uses it anymore.
Huh?
What I'm telling you, see,
Yeah,
the message you want to give to the audience is, I mean, I want to give it is, as soon as you say whatever, if it is adhesive capsulitis, what you're trying to say is, it is a disease which has a spontaneous recovery over a period of time, in broad majority of cases. If you specifically say adhesive capsulitis, you are communicating that to me. If you say frozen shoulder, I would say it could be because of any other reason also.
No, that is because your understanding.
I think you clarified.
Yeah. So is everybody clear about the frozen shoulder? Any doubts? We now know that motions of the shoulder can be restricted because of osteoarthritis, impingement, dislocation, locked posterior dislocation, any other problem. The movements of the shoulder can be restricted. All these are not frozen shoulder.
Sure.
Frozen shoulder is these three. If all these three are there, then it is a frozen shoulder. We'll quickly go to the. I just want to know the idea of your practice, because what I used to work 5 years back is my practice is totally different than what I have right now. What is the incidence of frozen shoulder in your practice?
Just considering that frozen shoulder and adhesive
Idiopathic
capsulitis.
frozen
No,
shoulder.
no, just one phrase before answering.
Okay.
Adhesive capsulitis and frozen shoulder are not the same. They are brothers or they are even cousins.
Yes.
But adhesive capsulitis is the disease in which we don't know where it comes from. Affects women from 40 to 60.
No. There is.
Yeah.
I think there is no difference
No.
between
It's
frozen
exact.
shoulder.
Frozen shoulder.
You know the cause.
No,
It can be.
no. Frozen shoulder.
I'm gonna have to open the book.
Frozen shoulder and adhesive capsulitis are exactly
the same. Yes.
It's frozen shoulder. It's the name that Codman gave it. And,
No, these are the symptoms, yes.
And Advisor in 45, the father of Bob Advisor, in 45 coined the term adhesive capsulitis. It's exactly the same.
It's exactly the same thing. Yes.
Okay.
They're different terms.
So you want to know the
Yes. What is the incidence?
2 cases a year.
2 cases a year.
2 cases a year.
So one of the ways.
We are talking
Every day, how many
about not the post-surgical and not the
Every day in your practice,
I
how many
see.
new shoulder patients you see?
a week.
A week.
A week about.
Let's make it simple for just the audience. What is a frozen shoulder?
It's not clear yet?
They were confused.
Oh, okay. So I think you will.
It is same as
Okay. So
Call it adhesive capsulitis.
yes, you can call it frozen shoulder. You can call it adhesive capsulitis. They are both the same things. And whether you call it adhesive capsulitis or frozen shoulder, they have to fulfill the 3 criteria.
Yeah.
No radiological findings, joint normal, rotator cuff normal, by and large normal. Though may be slight partial tear and all that, I don't consider them significant. Maybe 1 or 2 acromion, no problem. And no history of trauma. I mean, trauma doesn't mean only injury, surgery also. So it is not a post-surgical stiffness.
Sure.
It is not an injury.
Sure.
Okay?
So what I see 40 to 50 shoulders.
Is everybody
a
clear
week.
now? Yeah? Okay. Sorry.
I see 40 to 50 shoulders a week,
Yes.
and I have 2 cases a year.
2 cases a
3
year.
cases a year.
So I mean the percentage is 0.0000 whatever.
No, I see much more. I would say about 20% of my population will have frozen shoulder.
Okay.
Yeah.
Is it because you're seeing more trauma than old people?
No, I see a lot of degenerative things in the office.
Okay.
Over 30% of my total shoulder.
20 accomplished shoulder surgeons or people who do who have a significant shoulder practice have 10, 20 or 0.1%. What about you? Would like to add? 20%. Isn't it different from what we most of us think? Somehow most of the doctors have 50, 60, 70% of frozen shoulder incidence. Why do you think it is? Are we misdiagnosing them? Are we missing out on the rotator cuff injuries or the partial tears or the full thickness cuff tears or osteoarthritis, even osteoarthritis? I know it is rare, but it can still be there. Okay, what is the refractory frozen shoulder, Sergio? We'll start with you again. What is the refractory frozen shoulder where you will think of intervening? It's not responding to your injections.
It's not responding to conservative
Your conservative treatment.
management.
Yes.
Nothing less than 6 months. But as long, this is a very important message. As long as the patient is evolving clinically, 7 months, 8 months, 9 months, I will continue with my conservative management. That is suprascapular nerve block that I have been doing for 9 years with very good results. But actually, as Offer said, in 2 years the patients would get better, but we have to make them suffer less. So we have to shorten the time of the disease. And generally, after 4 months, 5 months, my patients are much better. So for me, I indicate one surgery a year. One surgery. Yeah, because all the other patients do fine with conservative management.
I am much more aggressive.
Okay.
Maybe it's the population.
Yeah.
Maybe the population will not accept it. I think of myself, if I had a frozen shoulder, I wanted it to be manipulated tomorrow. Because I don't want to suffer for 3 years. Why? I mean, I'm in the prime of my life. Why to suffer for 3 years? So I would...
Just a minute, let me ask one question just to qualify, because we are having two totally contrasting point of views.
Yeah.
Yours is mainly private practice. Patients are paying for their surgery.
Just
Most of them?
Insurance and insurance companies.
Insurance company. And yours?
NHS and private.
So NHS
They don't pay.
50-50?
Oh, more or less, yeah.
Okay. Okay.
But the decision is exactly the same. It's not nothing to do with the payment, because we don't get much payment for the anyways.
No, I mean, patients that they're wanting to pay, are they still open for surgery?
They're open for surgery because, again, these patients are suffering, really suffering. They're painful. They've been painful for 3 months until the pain starts to
decrease,
to stabilize, and they come to the second stage.
Second phase.
And then, I give them the options. I tell them, listen, we can.
Right on the first day? Right on the first day?
They come to see me about 3 months.
3 months. So when do you decide that this is a refractory frozen shoulder? Okay, this might
No,
be my intervention.
All of them are refractory.
All of them are refractory.
If a patient comes to me in the first month with painful shoulder that starts to be stiff, and I think maybe he is developing a frozen shoulder, I'll give him 1 steroid injection into the glenohumeral joint. This might change the story.
Right on the first day.
When he comes to me, as early as possible. If I miss the first month, there's no point. No point of injections.
Okay.
Then if he comes to me after 3 months, he's already stiff in the second stage, I will offer him the 2 options. Say, listen, one option, which is a viable option, I've got a good friend in Brazil that is his favorite option. He can, treat, we can wait 2 or 3 years, it will be fine eventually. And the other option, I say, well, I can do a manipulation. And I do manipulation, and what I do, that I shorten the period from 3 years to less than 3 months, to 7 weeks. And you'll be
3 years is usually too much. Usually most of my patients respond within a year, just the figure said. 3 years, everybody...
No.
How many
The
patients-
natural history of the disease
2 years
is
to
from
3 years.
1.5 to 2 years.
So there's one panelist who gives a steroid injection, the glenohumeral joint.
So
The
Sergio-
other one gives a suprascapular nerve block, presumably in the clinic.
In the clinic.
So what should they give?
But that's only pain relief.
No. Each week they are getting better. This is
Ashish, you're on the...
this is a technique.
I wanted to talk about this.
This is a technique that Brazilian doctors are the guys who have most papers. There is a guy in Brazil, much probably offer knows, his name is Sergio Quequia, the same name. It's probably the most famous shoulder surgeon in Brazil. He made 6 papers, 5 or 6 on suprascapular nerve blocks to treat adhesive capsulitis. I read all of them. I started to do this 7 or 8 years ago. The magic number is 6 weeks, once every week. And after each week, the patients are getting better, and I stimulate them to move in the bath with water falling. And generally, after 3 to 4 months, they are much better, and they disappear from the office because the range of motion is much better. So I can generally shorten the time of the disease to 4 months. So to me and to them, it's quite reasonable.
Okay. So suprascapular nerve block, intra-articular or subacromial injection?
No. Intra-articular, only one in the first month.
Under radioscopy control? Under
No.
ultrasound?
Just.
Oh, that will be a different debate now.
Okay.
You are giving an injection without intra-articular in the frozen shoulder without any. Okay.
Well, my typical patient comes to me 6 months after he has had some kind of a shoulder problem, and he's taking some physiotherapy paper, and I tell him this, for next 2 months, I tell him for next 2 months, I'm going to put you on supervised physiotherapy, which will include two injections cortisone, possibly in the shoulder, somewhere around the shoulder, and with that there will be a pain relief and followed by supervised physiotherapy for 2 months. After that, if they don't improve, they go to the OT.
Okay.
Which I do out of, say, I see about 20 shoulders in a week, and you can calculate how many in a year, and I do about 4 or 5 arthroscopic releases in a year.
Okay, no, we are coming to that later. So suprascapular nerve block.
One question.
In just a minute, let me summarize what they have said. Suprascapular nerve block for him. Intra-articular injections.
Only, again, the minority, because I mean, they come to see me usually after 3 or 4 months.
So let's say,
there's no
in
point
first
of
month.
that. I'm not giving any injections. I don't want to get the wrong impression. I'm not giving injections. The unusual case that will come to me in the first week that skipped the GP and managed to get to see me early, this is the only guy that give you injections. Otherwise, I don't give any injections.
And this physio for some time, if they don't improve, injections. Let's hear a different point of view.
And usually, just one thing.
Okay.
Usually they come
in. That's why. Let's hear what you do.
Just one thing. Usually they come in and they complain that they had physio and the physio made it worse.
Yeah.
So, I consider myself as the chairman of the Society Against Injections, Against Manipulations. We don't give steroid injections. We see a huge volume of patients. On an average in a week, we must be getting almost something like 80 to 100 new patients.
80 to 100
new patients. We're a big unit. We have a fantastic rehab program, and we are very hard on this. And our understanding is that a caveat is very clear that patients come to us for a 2-week supervised PSRP program, Pune Shoulder Rehab Program. In 2 weeks' time, they must be 50% better in terms of pain, movement, and strength of the supra-infra. The key muscles are supra-infra.
You document them, the pain.
We have very hard outcome measures, paperless system. We measure their VAS scale orally. Just ask them, what is your pain? 100%, 80%, we note it down. We measure their supra-strength, infra-strength. We measure their forward flexion, abduction, external introduction, all these patients. So basically we have a UCLA score on them. And we must have 40, 35, 50% improvement in each level. The true frozen shoulders, which are the difficult ones, typically come back in 2 weeks with good relief in pain, good strength generation that they are recruiting, and the movement improvement is forward flexion, rotation poor improvement, which is still okay with us. That means that they are responding. We send them on a home program for a month. 70 to 80% of these at 6 weeks would have sorted themselves out. They'll need a little bit more supervision. They might come back for a week's supervised. Otherwise, if they're doing well, 80% better, we just send them off.
So basically, you are what they are trying to hasten the process of release. You are doing it just by exercise.
Exactly.
Okay.
So I have gone through ups and downs. When I started off, we thought much younger days, that arthroscopy release is fantastic. We went through that and we had disastrous results. In the sense, there is no consistent result like your cuff or Bankart, where 80% patients are going to be good. Sure. Whichever way, you do single row, double row, doesn't matter. Yeah. So some patients are brilliant. They would think you are God because you relieve them from misery. Yeah. And some patients are just exactly as they are. Sure. And if a frozen shoulder release patient fails to comply with rehab because of pain or because somebody passed away, he is so miserable that he'll curse you for the surgery. So there was a time between 2005 and 2008, I just stopped doing any arthroscopic releases. Now, kind of matured mind now, so we kind of do 3 cases which have not responded to the rehab. Those are typical 3 years frozen shoulders, 4 years shoulders. They've done 3-month rehab, and zilch improvement is 10%. So if there's 20% improvement, I will still push them.
No, I got my answer.
You got it? Oh, okay.
Okay. I just want to make a geographical comment, very important. This is a medical geographical comment. I live in the second biggest city of the planet, 20 million people. Every day, the traffic in my city
became chaotic. So people do everything not to get to the road. People are working in my country every day more and earning less. So every patient tried not to go to physio. This is a reality of my place. So once I offer them a technique that I like, that me and my friends have been using for almost 10 years with so good results. When I teach them to do some movements in the bath at home, and I say you won't have to go to physio, they say, doctor, I love you.
Okay, then, okay.
There are two randomized control studies of manipulation versus home rehab.
Okay. Yeah.
Both studies at the end of
No
3
difference,
months,
no difference, no difference. But not with suprascapular nerve block. They are not with the nerve block.
That will third study comes from.
Yeah, that will come from him. You want to say something?
Why you are afraid of giving the steroid injection? Why you don't want to give it?
Why you don't want to give injection? Why do you need it? If it is recovering without it, why?
Because he told us.
If my patient go on the rehab, the pain starts coming down the 5th day. We don't give analgesic, we don't give steroid injections. I don't need it. If somebody fails my rehab and still has pain, which happens once in a week or once in a month, we still give them the injection. I'm not saying no injections.
Maybe we're treating different populations.
No. Frozen shoulder is very common in India compared to Western population, the incidence.
No, but I think it's different populations because in England, if they do physio, they come back crying. The physio made it worse.
You can make it worse if the physio is unscientific. If Amit allows us, we are going to do a very brief talk on the scapula.
Okay, in lieu of your arthroplasty?
I think why I give injection is actually it relieves the pain of the patient. Maybe steroid working as anti-inflammatory, and it is easier to do physiotherapy on them after that. If you do it without that and they are painful, they don't want it. The physio makes it more painful. They try to stretch it out. And
Okay, I think most of the rest of the questions on frozen shoulder have already been answered, I think, in the discussion during the talk. We can cut short that and resurface the glenoid. We can talk about the resurfacing the glenoid.
Or not.
Yeah?
Or not.
Yeah. You want to come over, Ashish?
Yeah, sure. कर देंगे. So not a talk. Shashank asked me 1 hour back that he needs images for the resurfacing thing. So I said, so we just grabbed images here and there. Just 2 or 3 cases just to give you an input, and none of the cases are a standard shoulder replacement patients because I think there's no challenge there. So this is a 62-year-old chap, last 3 years suffering. Now question is, resurface or just do a hemiarthroplasty, leave him alone? He's been having pain for 3 years now. He's a husband of a MBBS doctor, 63. Yeah, 63. In pain, he started getting morning stiffness so 4 months before he came to see me, his symptoms have gone worse. He's significantly disabled. He's a pen pusher, but question was, do a hemi or do a total shoulder, or he needs intervention now. So how many would do just a hemi for him? Yeah. So I used to be like that. So 5 years back I used to be like that. Most of the time do a hemi and not do the glenoid, because it's like the TKR approach where not resurface the patella, because all the complications relate to patella side, and most of us shoulder surgeons didn't have enough confidence in the glenoids that were available in the market as such. That's why.
I just have to add something, because we do, and we looked at our series, we looked at the young patients, less than 50 years now, with 10 to 25 years of follow-up, which is a long follow-up. And the ones that we did, only resurfacing of the head, what we do, we don't ignore the glenoid. This is a key point. We do the release around the glenoid as if we're going to put the glenoid in. We prepare the glenoid, we just stop short of putting the plastic in. And what we do a microfracture. Now, this is the key point, because if you ignore the glenoid completely, just put a hemi, the results will not be as good, and you'll have erosion. If you do the whole thing and then put the plastic, That's
But irrespective of whether you do a surface replacement or hemi, the laborectomy has to be done, the soft
Yeah.
tissue mobilization has to be done because you want to rebalance the shoulder.
Absolutely.
So all these patients, I do a biceps tenotomy, remove 360 degrees of labrum and work on the subscap to get as much length. What I've noticed in India is because they come in late and they come stiff, there's a very severe limitation of how much subscap you can mobilize. And then that decides how much external rotation, that decides how much abduction. I'm simplifying the whole game, but the gist of it is the lesser external rotation they get. And so if you don't do too much work on the subscap and just accept it, just put in a stem and come out, then the movements are going to be stiff. So a lot of work needs to be done there. So we did do a total shoulder replacement, put in a glenoid there, done this.
How was his curve? Because this is an important thing. How was his curve?
Oh, if there is no cuff, don't do a total shoulder.
Huh?
Don't do a total shoulder. The cuff is good.
The curve is okay.
Cuff is good. Cuff is good. Not okay, good. So only if the rotator cuff is good will I do a total shoulder replacement. If the cuff is dicey, halfway there, I might do a hemi or a surface, but no, I mean at 60 I'm not so sure about the reverse SR. So doing this, he's now 3.5 years post-op. Again, his subscap was too tight because he sat on it for a long time. He has a reasonable range of movement. I should have had a video somewhere. No. Another 58-year-old lady, last 3 years osteoarthritis, lot of osteophytes, lot of spurs in there, and concentric reduction. So, offer for planning a total shoulder, what are things, red flags that you're looking for?
Well, I need to have an axillary view to
Yeah.
see the
Yeah.
glenoid,
Yeah.
because it depends on the
Let's see.
erosion, posterior erosion of the
Yeah,
glenoid.
not this one, but I'll give you the next one. But on the whole, not this patient. What are things that you must know before you agree to do a total shoulder
Well,
replacement?
You need to assess the status of the rotator cuff.
Yeah,
which this
absolutely.
is the key point. If you have superior migration of the humeral head, what the acromial distance. I mean, here, for instance, is a big spur
Yeah,
as well.
yeah.
I'm not sure the distance is very limited, but maybe it's a
But
protection.
cuff is very good.
This may be
Cuff
a
is very good.
protection, So
Yeah.
I'm not sure. You have to look at the Shenton line.
Yeah,
This will
yeah.
give you
Yeah.
an idea what's going on.
So that's an osteophyte there. So Shenton line is okay. This whole thing is an osteophyte.
The other thing is on the axillary view to see the glenoid, to see if there's no posterior erosion of the glenoid, the double.
So the B2 glenoid. Yeah. So what if they have a B2 glenoid?
That's a problem. That's a problem. And I tell you, if what we would do is we burr the central ridge.
You do a run and ream?
Not
No.
rim and run.
No.
Not rim and run. Just burr the central ridge. Keep the hard bone on both sides and do the microfracture there. The key point is to get the length of the subscap correct, because what happens otherwise, it pushes it back. So you need to get at least 30 degrees easily on the table of excitation.
So let me try and recapitulate that for you. What offer means is that most of the primary osteoarthritis patients will wear out on the posterior glenoid side. So there will be a good anterior glenoid, and then there will be a dip posteriorly. So that's called as a biconcave glenoid. Now if you just do a glenoid replacement on that directly, then there's not going to be a good support posteriorly. That's the glenoid that's going to start rocking and start getting loose much faster. And that happens because of the dynamics of forces, because the external rotors tend to be weak, subscap is much too stronger, and so the head tends to go sublux posteriorly. So be careful of the B2, and unless you do an axial X-ray or perhaps do a CT scan, you'll miss out on that. The CT is the most reliable.
That's what I wanted to ask.
For the reverse shoulder, I get CT for
Mike.
everyone.
Yes.
For the anatomic shoulder, I probably ought to get, but I get for much. I would say if I have any doubt, I'll get a CT. I get good AP and axillary view. If I'm not sure, I'll get a
So
CT.
why this discrimination? Why only for reverse? Why do you get CT for reverse?
It's just because I know that if I won't get the CT, I'm getting the CT for the reverse because I'm prospectively looking at them. So
as a part of study,
yeah.
not to make a clinical diagnosis.
Well, it helps.
Okay.
But it's to assess the bone stock and to be able to assess it in retrospect if any of them will fail. What was the mistake?
Okay.
So if I don't get it before the operation, I will never get it. So I do it. But thinking about it, I should probably get it for the others as well.
For total shoulders too.
Yeah. We do an MRI for total shoulders,
Yeah.
basically to know that there's enough curve there to justify the
Sure.
ship replacement. That actual cut will tell you whether it's a B2 gland or not.
Yeah,
If
yeah,
there's
you can see
excessive
from the-
erosion,
yeah.
on the
then those
MRI.
pre-selected patients will send for a CT.
Ask for a T2 axis.
Yeah.
T1
For the reverses, you need a CT because you want to know how your metaglean is going to sit in there. So if it's a B2 glenoid, then you have a problem there because on the reverse you get only one bite at the cherry. So if that doesn't go through well and you need to know the axis and the
Just a
version.
small comment, especially for the audience.
Mike, please.
You can see on this X-ray, on this here, you can see on this, even if the curve is okay, and I'm happy because she's only 58, but you can see here two radiological signs, if you give me the point in a minute, that are indirect radiographical signs of curve arthropathy. The acetabularization of the acromion and the femoralization, I don't know how to say in English, I'm sorry, of the proximal humerus. So this curve is, this shoulder is already starting the journey to a curve arthropathy. So this would make me get a little bit more worried.
You're right, the signs are there, but the cuff was good. We went in and treatment. She has a very good, yes, sorry, there's a question we missed there.
Can I see the previous post-operative?
Yeah, yeah. This one?
Actually, sir, what we were taught that your graded tuberosity should be 2 to 3 millimeter above
Yes.
the articular surface of the...
Below.
Below.
sorry,
Below. Below. So somebody, I forgot to miss a point. If there should have been a critique of this X-ray. If you see there, the fracture. So we've osteotomized the greater tuberosity because there's a mismatch between the version and the tightness. So because it was too tight, we had to slide the GT down a little because we put a smaller head. We put a very small head for a male. Now, because we did a small head, we didn't want the GT to be prominent, so we trimmed the GT, osteotomized, because this is osteoarthritis, it's not a fracture patient. But that's the paradox in Indian patients. They come in so tight that I would actually decide to do the GT, slide it down, and fix it there.
And just again for the audience, a very important thing that was done here is that you put a stopper. You put a stopper
Yeah,
below
yes.
because this is very important for revision.
Yes,
Yeah,
yes,
very
yes.
important.
Yeah, especially, when you're revising your old cases, I'm worried because it's all well too cemented. Somebody else's revision is reasonably okay. But Shashank, I would never do that 5 years back. But I realized that it compromised my results. And that happened too often because they're coming so late. There's a very severe limitation on how much subscap I can get out. So if I can't get a subscap out, I put a small head. If I put a small head, I can get 30-35 degrees of subscap. But the small head makes the GT go proud.
Yes.
So there's a contradiction there. So then I started doing this, and that kind of balances the equation for our patients.
Ashish, if you would done a surface replacement, you would avoid all these problems. No, seriously.
Yeah.
There's no need of a stem there.
But what do you think about the famous zeta plasties or the plasties to get some length on the subscap? I never done.
Yeah.
It's written in many papers.
I don't like it because it drops the power by 1 straight away.
Yeah.
And they are wasted. The subscap is so thin that
the Z-plasty is not.
Okay.
it doesn't work because it drops their strength down.
Okay.
I'd rather do this because at the end of the day, as somebody said, Offer said, it's a complete soft tissue operation. You must achieve a balance. If you can't achieve the balance between a subscap and your rotator cuff, then this patient is just not going to do well. This patient will lead a good function provided you can achieve all the soft tissue balance and the length tension relationship between each other. So coming to this patient, this is what we done. This is the contradiction I was talking to you about. See, that GT remains, in spite of having a small head, my GT is still prominent in.
Yeah.
So this is one of the older series. This is what happens. Because my GT should be 3 to 5 mm below the head. And because I get very little length on the subscap, there's a limitation how much you can mobilize it. This is what used to happen. So now I just do an osteotomy, pull it down and hold it there. Go slow on the rehab in those patients because you've damaged,
What's
osteomatic.
happening is actually all this problem is because you're using a stem prosthesis,
Hmm.
which is deciding the position of your head.
You're rubbing it in now. This is what happens when you sit next to offer all the time.
No. So what trick I use? Of course, there are a lot of patients where you have to use a stem prosthesis because if you're doing total shoulder, you do both and cut it off. But I think what I do is I ream it one size higher, or the best size possible, in the humerus, and then I use a stem one size smaller, cemented. So I have a maneuverability on the head. I can put the head.
That doesn't work. Don't do that. I will tell you what happens.
Yeah.
Whenever I've underreamed, and sometimes I do that for fear of fracturing the bone, I've ended up putting the stem in varus.
No. So this
The
is
stem size does not influence my head size.
Let me tell you, I'm not bothered about the stem position in varus or valgus. I'm not bothered about it. What I'm bothered is whether my head is in the proper position.
But you
Doesn't
can,
matter.
this is a modular process. You can put whatever size head on whatever the stem.
Let's get it clear. It doesn't matter where the shaft is going. Where
Yes,
the
it doesn't matter.
No,
to
it
me.
matters. It
Does-
matters.
No, I
It
want to put
matters.
the head in the proper place, like anatomical position of the head, even with the stem prosthesis.
But what's the problem if you put a size 10 stem and put a 40 head on it? You can, if what you're trying to do is put a 8 stem and put a 40 head on it.
And then manipulate it while it is cementing in such a position that it sits exactly at the cut surface in an anatomical way.
But sitting is not a problem because the cut is taken by the jig, it goes in by the jig. So the alignment of the stem
He's trying
is
to
not a
improve
challenge.
Having a smaller head is getting us little more play because of that contracted subscap. So how will
So which kind of a process do you use?
This is the Zimmer, this is the big Lenny Flato.
Can you rotate it?
100%. It's a dial-in process, everything in dial. See, the point is, if I drop this size down, it's very important my subscap sits in properly. In 30 to 50 degrees of external rotation. But when I do that, I get this contradiction because the head size has been small. Ideally, this patient requires a 46 head.
And you get the point pressure as well because it's a smaller head. You get the point pressure.
Okay, last case.
Sir,
Avian.
Excuse me,
Yeah,
please,
sure.
please clarify, if there's a varus or valgus stem, what is harm is it going to produce?
It changes the biomechanics. You want, this operation is about restoring anatomy. So you must always restore anatomy and try and eyeball the size pre-op so that you can put in the maximum size stem. If you put a maximum size stem, you cannot go into varus or valgus. Whenever you undersize, it tends to go into varus. Happened to me. Yes.
Move like
Why
Yeah.
would you need to, now that you've chosen a smaller size head, could you not have left the stem a little proud because you put a lot of cement around it?
Yeah, I agree. Putting it proud will again take my subscap away.
That's what was worrying you.
Yeah. So balancing both the things is,
already smaller?
it's,
Not the head size.
no,
I'm talking
it's the
about
same
head
thing.
Level.
Yes.
It's the
If you
same
tighten
thing.
the subscap more. It's already
No, 1 minute, Shashank.
Yeah.
Putting a large size head,
Not a
or
large
put,
size. Yeah.
putting the large size head, or putting the stem a little proud are the same things as far as subscap and length tension are concerned. You're overstuffing the joint.
How to solve the subscap problem?
No, you balance the subscap
Yeah.
and do an osteotomy GT so you can pull it down a little.
Can you say again? You balance it?
If you're using
Then
a
osteotomy.
larger head.
Yes.
And so that you can pull it down a little.
Then you're tightening the subscap.
But you know,
If you use a larger head, the bulk is more, the subscap becomes tighter.
Tighter.
Why would you tighten it if you're getting?
You don't want it tighter.
No, if you're a smaller head only, you're not keeping it higher. You're not pushing it all the way. Bulk is not increasing. This is what we do in hips, right? We do the same in hips. We can take, sorry, I'm more of a hip and knee surgeon, but if you're stuck somewhere about the length, you can leave the stem.
No, but this subscap insertion is an oblique insertion. It's a long 5 centimeter insertion.
in the front, not at the top. It is in
Yeah.
the front.
It is in the front, but putting it higher, the upper subscap will not match your insertion point. Try it next time you do a trial reduction. Try it. Because it's, in short, it's overstuffing the joint. You must not overstuff. So these are measures to try and understuff the joint so that I can get a soft tissue. At the end of the day, you want a parachute closure where the whole soft tissue is closed down and is stable in 30 degrees of external rotation, 90 degrees of abduction. So, next
How
one.
will, just a minute.
Yeah.
How will getting the GT down will understuff or rather.
No, it's not understuff. It gets the GT head axis sorted out. You want it to be 3 mm below, na? Because of this situation, it's 3 mm proud.
Okay,
You want
burr
it.
that a part of GT. You burr a part of GT.
You can't burr it down. You pull it down. Your student slide it down.
Yeah, the only problem with that, there's a famous study of Pascal Boileau, we have to osteotomize tuberosity. The results are not as good. So you had a lucky escape from.
No, I've been doing this consistently. We've not had a problem with flying off the GT. We do go slave. The only problem with that is you can't do it for every level. You get a 3 mm plate, that's it.
But if you do a GT osteotomy and if it goes to non-union, you lose everything.
I agree. I completely agree. But we do a robust repair. It's a nice circlage Frankel's stick. No, we do number 5 Ethibond. Frankel's technique with the circlage thing. I should show you some of our fracture patients.
But non-GT non-unions.
No non-unions so far. Touch wood. See, there's a risk involved there, but we are doing this for the last 3.5 years now. Well, I think my priority is balancing the shoulder. Don't expect the GT to come down 1 centimeter down. It's not coming. It will over-tension the rotator cuff. You get a play of 3 to 4 mm. That's it. So when you're struggling at 3 to 4 mm, then that's what you should do this.
And do you use intra-op
Siam, 100%.
Because you didn't mention, I think that
100%.
it was important just to
Yeah.
see, yeah.
Last case. Woo! That one, anyway. So that was a oops moment. Anyway, this is a 44-year-old guy, AVN, so I'll go up and elaborate. The problem with him was he's getting more and more stiff, disabled, and he's lost his movement. So he came in for surgery. The plan was to try and do a surface because he's young. We said we can't promise you. We prepared for the surface, ringed it, and then we got a big cyst in between. So that cyst was almost.
You do bone impaction, a bone graft impaction.
I thought about it.
Substitute impaction, and you do it. And
I'm not sure. I thought that was a little risky.
One of my fellows said that I had 120% loss, and I did it. It was concave, and I did it with bone graft and substitute impaction, and it works well.
Yeah, so I didn't have the guts to do that, so we did this eventually because we had kept both prostheses available. This is his 5.5-year follow-up, and he's very happy. He's consistent.
How is his pain now? No pain?
No pain.
It was very painful.
He was in great pain. He is absolutely back to normal. He is an entrepreneur, businessman, travels a lot all across the world. He's very happy, and this is a concern. Every year he comes regularly for his follow-ups, for his X-rays, for his measurements, and we seem to get a good.
Just a question for you. A question for you and for offer. In San Diego, it's funny because if you go many years, you'll see that what people were saying 5 years ago is now not the truth anymore. So there is a guy from Mayo, John Sperling, that he used it to do some grafting in the glenoid with lateral meniscus and there's the Burkhardt surgery, the Burkhead. So what is your experience with some kind of
interposition? I don't do it, but I have asked experts around the world. So we talked about this with Suman Butch, then I talked to Jared Beer, and there's no evidence there. And they said some patients are brilliant, some patients are zero.
The idea is nice.
Idea is nice, but some patients they say zero improvement, some patients they say very good. So that I don't like because there is no science there. There's no science.
Of interposition in hemi in young patients.
I personally, what I do is I do the microfracture with results. So I know that Bas Burkhardt had good result, and others. J.Q. Warner had a horrible result, and I think Tony Romeo as well. So definitely don't use the meniscus because the meniscus is too thick. And I think the most important thing is to do it with the microfracture. Because if you don't do it with the microfracture, you don't allow any
fibrocartilage.
Any fibrocartilage. But in this guy, the cartilage is fine. So why would just do a?
No, his glenoid was absolutely pristine. He was shining glenoid. Just quickly, I want to ask.
Can you please elaborate the post-op rehabilitation program? How do you?
Okay, we'll do that after this session. Yeah. So, 53-year-old lady and in great pain, severe morning stiffness. Loss of joint space. Anybody agree? Yeah. So I would have put it for you and the panel, but we don't have time, so I'll just move on. This is oblique X-ray. So this is a very deceptive X-ray. Okay, and this was the original X-ray. See, same lady. X-rays taken within 3 days of each other. So this was the original X-ray which she came with. We said no, we want a better X-ray, and the true AP did not show it. The oblique actually showed it, and great pain. So this is what we did. So we do surfaces.
This time you did the right thing.
Save the best for the last, but this is how it should be, and this works. And the younger patients, I'd be happier to do it. 100%. You never do this without a good cuff, and here version is not a challenge.
Okay.
So here tensioning is not a problem.
What's your longest follow-up with?
These are 7 years now. We've done about 8 or 9 of these right now, but 7 years, and very young patients, very young patients.
And still, they are okay.
All of them are 35 UCLA. There's one lady who's got very stiff muscles, so she's just coming up to here, but no pain, no migration, no loosening.
And
So she's the only one who's stiff.
And this is cementless.
This is cementless. This is cementless.
Okay.
Cementless.
This is not the real thing. It's a copy, but yeah, it's still okay.
No, when you template the head on this directly, I have a separate presentation, you will see that head sits exactly like this, which means that you have replicated anatomy. Right, we'll call it a day here.
Thanks a lot, Ashish, and sorry for trimming you down. Professor Levy has to leave, and a very, very big thank you to both the international faculty present out here, Sergio and Professor Levy. It's been a delight having you over. No, I'm just. And an equally.
A photo.
Yes.
Yeah.
Can you?
And an equally big thank you to our very, very esteemed national faculty who have really kind of taken out their time and really got involved out here. Thank you very much.
Okay. Yeah.
Can you please take a photo, please?
Yes.
The last session, the training opportunity bit, if you just get in touch with the IOACON2013@gmail.com, and we'll give you all the details, as Kapil did give yesterday, his details, but we'll give you all the details as to how to approach them, what is available, and so on and so forth, to make it simpler for you to train with them on various kind of durations. Thank you very much. A very big thank you to the audience, because without you, there is nothing out here at all. Thank you.
That's okay. I like it. What's the point, everybody? I expect you why.
There's the fighting.
There was a lot of fighting this time.
Yeah.
Thank you.
Somebody said, yeah.
There's one more.
There's the guy.